All right, next we will have Professor Madhya, Dr. Sharul Shazliana, will talk on the treatment of gout. Prof is a consultant rheumatologist from the university, her hospital University Kebangsaan Malaysia. Without further ado, Prof.
Hello, Assalamualaikum. Hi everyone. Good afternoon. Thank you for staying up till the lecture 3. Congratulations to everyone for staying awake. I hope you have coffee by your side by now. Okay. So I think I'm just going to go through. I'm sure there will be a lot of questions. So I hope from this talk, so all of us will be able to learn on the types and indications of uric lowering therapy, which is the cornerstone of treatment of gout, and how do we approach patients with acute gout flare, and how can we prevent those from happening again, and how to manage gout in special groups, role of adjunctive therapy, and how do we monitor them, and what are the time and indication to refer to other specialties such as rheumatology, orthopedic for the gout patients. So we have heard a lot about uric lowering therapy, and I think there's a lot of myth and stigma with regards to this. That's why I think there are some hesitancy even among the healthcare professionals to initiate uric lowering therapy. So I hope this talk will be able to debunk some of the myths of ULT. At the moment in Malaysia, we have two types, two classes, xanthine oxidase inhibitors, which are allopurinol, our old friend, and the latest one is febuxostat, uricosuric agents, benzbromarone, and probenecid. We do not have pegloticase or recombinant uricase in our country. And we aim less than 360. I think this has been explained multiple times before. So we treat to target. So the question comes, when do we initiate? Are we going to initiate the ULT at the time of flare, or should we wait? As we all know that any change in the uric acid level can induce flare. So we have to be very careful when we initiate uric lowering therapy. We have to explain to the patient that this is not a painkiller. So traditionally, we do initiate after a complete resolution of gout flare because we don't want to add more oil in a burning fire, right? But sometimes we found that many of patients have a very frequent flare. For example, in fact, it looks like there's no pain-free intervals. So what we do usually is we can start at the time of flare, but we manage the pain appropriately. We control the pain appropriately. So meaning that you treat flare plus you initiate the uric lowering therapy. So again, this is based on a shared decision with the patient. So what are the indications of ULT? So it is very important to know the indications. Not all patients with hyperuricemia require treatment for ULT. So these are the established indications, which recurrent gout flares defined as 2 or more episodes within 1 year, presence of tophi, or presence of radiographic damage attributable to gout. So, but ULT may be initiated, maybe meaning that the indications are not that strong, but you should consider to start patients for first gout flare, especially in patients with CKD or very high serum uric acid concentration, more than 540 or 9 milligrams per deciliter, and patients with kidney stone disease or urolithiasis. So first we talk about our old friend allopurinol. So allopurinol is the oldest and used to be one of the xanthine oxidase inhibitors available in our country. Usually the side effects are mild except for the presence of severe cutaneous adverse reaction. So it is very important for all of us to counsel the patient on the symptoms. So the symptoms can be just a prodromal symptoms of fever, flu-like symptoms. So all this need to be counseled and need to be documented. So the reported risk factor for these side effects include a higher starting dose, patients with renal impairment, and patients who has this genetic allele of HLA-B5801. So why is it important for us to counsel and document this? Because we are living in the medico-legal era. I have encountered probably few cases who actually threaten or even want to proceed with a lawsuit because they were claimed that they were not given an adequate counseling on these side effects. It is rare, but it is potentially fatal. So problem is this hypersensitivity syndrome can occur even in a later period of starting points. The range is about 1 to 1,080 days. So it's sometimes very difficult to recognize this. And again, like I've mentioned, it is very high risk in patients who has low EGFR or CKD. So that's why we practice to initiate allopurinol at a lower dose, 100 milligrams daily. I know that sometimes in some clinics, they only have 300 milligrams tablet. So sometimes we do, I mean, personally, I do like give half tablet. You just cut half and then try and take daily and titrate up slowly. So we don't usually start 300 milligram on the go. And for patients with CKD, I will explain later on the dose, starting dose, and how do we escalate. So we can actually adjust the dose every 4 weeks until we achieve the serum uric acid target. So, and most importantly, we have to educate the patients when you start an allopurinol, you have to take it every day. And if you have a flare, unfortunately, we have to also tell them that, you know, this is not painkiller. So it reduces the uric acid. So there is some risk of flare, but during the flare, the patient shouldn't discontinue the allopurinol. The dose should be continued the same, but we have to control the pain. Obviously, we have to control the flare, in which I will talk about flare treatment later on. So when do we stop allopurinol? So this is a tricky question. A lot of patients hate taking pills. So there are no recommendation to stop allopurinol because if you stop, the uric acid may go up again. So this a bit difficult, but we do try to titrate down the dose, but not to stop entirely the allopurinol. So I'll be talking a bit more about this HLA because, you know, the lawyer will ask you, doctor, is there any tests that you can do to prevent this from happening? I mean, we do have this genetic allele, but unfortunately, the screening prior to the initiation of allopurinol is not cost effective. So the guidelines, majority of the guidelines do not recommend we screen this, but of course you have to be very careful in a high risk ethnicity, in particularly Han Chinese, Korean, and Thai. So it case to case basis. So again, it is not routinely recommended, but if you want to send, yes, please go ahead. Okay, so it's just that for all for all of you to know that it is not a routine screening test. Sorry, why suddenly unmute? Sorry. So, sorry. So I'll just repeat it again. Febuxostat came, it was approved, I think, in 2018. It's a good drug. It is superior than allopurinol in reducing the hyperuricemia. But unfortunately, so very anticlimax, isn't it? The surveillance study, which is the CARE study, showed that the allopurinol has a bit of increase, although there's no rates of major cardiovascular events, meaning that the same, but there's a bit of risk of cardiovascular death. So that's why febuxostat remained as a second line, because FDA has issued a black box warning. And I think it is advised that febuxostat is as a second line of uric lowering therapy after allopurinol. If the patient did not respond to allopurinol or allergy to allopurinol, then you should consider febuxostat. So, but subsequent, I think a lot of other studies and meta-analysis as well as registries. And registries is like a real life database. So sometimes in in clinical trial, there are many, sometimes it's very difficult to judge based on one clinical trial, as there are many unmeasured risk factors, because we don't know how much NSAIDs exposure to this febuxostat arm compared to allopurinol, and whether they are adhered to the healthy lifestyle. So there are many unmeasured factors in the CARES trial. So, but it is very reassuring that the subsequent registries and subsequent studies do not show any high mortality in febuxostat, but FDA has not withdrawn the black box yet. So I think that's why our guidelines still put febuxostat at the second line of uric lowering therapy. Then we move on to uricosuric agents. So this uricosuric agents has a bit limited use because it doesn't work in patients with CKD, and and also shouldn't be used in patients with kidney stone disease. But sometimes in patients who had no other options, we do give uricosuric agent, for example, probenecid and benzbromarone. And in patients, I mean, I think this is usually in rheumatology clinic because I think when the patient is very refractory, this patient should be referred to specialist care. So we do give a combination of xanthine oxidase inhibitors and uricosuric agents in refractory patients. So these are the recommendation. Allopurinol is the first line, low dose, increase gradually. And if it is contraindicated or not tolerated, you can use febuxostat or uricosuric agents. And again, should be aware of the side effects of allopurinol, especially the hypersensitivity, and the initiation of the dose should be based on the eGFR, we'll show you later. But the routine screening for the genetic allele is not recommended. And febuxostat can be used even in patients with renal impairment, but it is contraindicated in uricosuric agents. So these are the recommended dose. I think you can find this in page 5 of the CPG. You can go through the initial dose, but please take a note, in those patients with CKD, you should start at 50 milligrams daily, very low dose, and even if less than 30, 50 milligrams every other day. So be very careful in this population. Febuxostat in patients with eGFR of more than 30, there's no dose adjustment, but in 15 to 29, maximum dose is 40 milligrams daily. There are no study which showed safety. I mean, there's no randomized control trial of febuxostat. Patients with eGFR or less than 15 are excluded. So that's why we didn't put that less than 15. So basically, it is an off-label use if you want. So these patients, I think patients with CKD should be referred to specialist care as well. So I think you can type in your questions later on. So then we go through gout flare. So again, it is very painful. So we do have few options: colchicines, NSAIDs, steroids, but we do not have the IL-1 inhibitor. This is a biologics and not available in Malaysia. So colchicine is a very famous drug. So whenever I encounter a patient with gout, they will say that, oh, I'm on gout nail. I say, what is gout nail? It's colchicine. It's not even a uric lowering therapy, right? So it is a pain relief for flare or prophylaxis. So I think we have moved on from a high dose colchicine. I mean, it used to be like take hourly until diarrhea, but please do not practice that again, because colchicine has a very narrow therapeutic index. So basically, the guidelines recommend low dose colchicine. So what is low dose colchicine? So low dose colchicine is not exceeding 1.5 or 1.8 gram or 3 tablets per day. So if you look at page 6, you can see that for gout flare, for colchicine, these are the recommended dose. So whatever it is, do not exceed more than 3 tablets per day. And a course of treatment flare should end once the patient had taken like 12 tablets. So because of that, colchicine has a lot of side effects, cumulative, especially in patients with CKD. So you notice that in the box, there are dose adjustment for colchicine, so be very careful. We've seen patients with myelosuppression, with severe AKI due to GI side effects, landed up in emergency departments. All right, so in patients with creatinine clearance less than 80, it is not advisable to give colchicine to treat gout flares. if they are receiving prophylactic colchicine. So I'll explain what is prophylactic colchicine later on. So NSAIDs, yes, I think everybody is aware of the side effect of NSAIDs, cardiotoxicity, nephrotoxicity if it's used for a long term. So what are the other options for patients who are contraindicated for colchicine and NSAIDs? So we do have steroids. Steroids is very effective anti-inflammatory for patients with gout, but again, it shouldn't be used for a long term. All right, so we can give 0.5 milligrams per kg per day or 30 milligrams daily for 5 days and stopped. All right, so usually rarely, because gout usually the peak is around the 48 to 72 hours, and within 1 week, usually the pain has resolved. So you can use it for a short term. Okay, so and there are no significant difference in terms of the efficacy, but of course, these are based on clinical meta-analysis, and it should be individualized. All right, so in gout flare, in recommendation number 8, you can use colchicine, NSAIDs, COX-2, steroids, and you can use the combination. But again, please, the choice of drugs are guided by the patient's comorbidities. Right. So those are the treatment of flare. But then how do we prevent flare? So if you remember, when you start uric lowering therapy, you should also start flare prophylaxis. So meaning that in patients with gout, you have to tell the patients you have to take 2 types of medications. Because number 1 is to reduce the uric acid level. Number 2 is to prevent flare of gout. Because I've seen many patients who were just given a ULT without flare prophylaxis, and the patient soon after taking the ULT developed flare, and quickly the patient will say, "Oh, this doctor's is not good at all. Give medication which cause pain," right? So pain is something that patient really can feel, but uric acid they cannot feel, they cannot see. All right, so yeah, so it's very important to initiate flare prophylaxis. So what are the type of flare prophylaxis? So the preferred choice usually colchicine, and because it has, I mean, for a long term, it has been proven at least 3 to 6 months, it doesn't cause any nephrotoxicity like your NSAIDs or COX-2. And of course, you wouldn't use steroids for a long term. It has a lot of side effects. So, but what if the patient has severe CKD? So which agent should be used as prophylaxis? So this, again, these are the group of patients, special groups. Usually you will refer to specialist care, and please do not initiate colchicine prophylaxis in patients with low GFR, less than 30. So it has to be adjusted. So in patients with CKD, again, allopurinol is the first line of treatment, but start very low, 50 milligrams daily, or even 50 milligrams alternate day in severe CKD. All right, so I've shown this before. Febuxostat is safe in GFR above 15, all right? So if GFR is above 30, no adjustment is needed, but uricosuric is not recommended. Again, colchicine should be avoided. Steroids may be used in gout flare, and of course, other adjunctive like topical ice therapy is also safe in patients with CKD, right? So how do we prevent flare in these special groups? So a very low dose escalation. So do not just simply increase suddenly. So obviously this will cause a major shift in the uric acid level. So it will cause flare of gout. So CKD stage 4, please do not use colchicine. Again, start low, go slow. All right. But you can go up to 900 milligrams. But usually in patient CKD, we rarely goes up to that high level. Again, in CKD, treat to target strategy still should be applied. All right, how about pregnancy and lactation? So there are very positive evidence in this area. So these patients deserve to be referred to specialist care. So again, should ULT be discontinued? I've mentioned this before. We do not discontinue entirely the ULT, but you may want, I mean, can be considered to reduce the dose slowly. But majority of the patients, we should continue at the same dose for a long term. How about other adjunctive therapies? There are many like, vitamin C, fibrates, statins. All right. So, but the thing is, this adjunctive therapy has not a strong, evidence. It has to be individualized. How about urine alkalinizers? So these are one of the, common treatment given in primary care as well as the, over-the-counter drugs. But it has a very limited role in reducing serum uric acid. So it is not recommended to be used in patients with gout. So again, more evidence is warranted, so more studies are needed. Okay, so I moved on to the monitoring and follow-up. So how do we ensure compliance? So this is very difficult actually, because a lot of our patients hate taking pills. But we just have to, re-counsel, reinforce, and you just have to tell them that, with the high uric acid level, it can cause a lot of issues with kidney deposition and kidney failure. It's not the other way around. It's not like you start allopurinol, you have kidney failure. But if you don't control the uric acid, it will cause kidney failure progression. Okay. And don't forget about the adverse effect, as I've mentioned before, that the hypersensitivity may also occur even after 3 months of initiation of allopurinol. So what to do? So you have to discontinue it, and if it's a very severe spectrum of scar, this patient should be referred urgently to the hospital. What are the investigations? I think Dr. Noliza has mentioned this before, so I don't think I will repeat this again. All right, so FBC, LFT. So we will do a routine blood test to monitor the liver function and the free blood count, because we know that allopurinol can cause myelosuppression. Fibrosustite has a mild hepatotoxicity, but sometimes it's very difficult because a lot of our patients with gout has metabolic syndrome. So sometimes it's a bit when they are very sensitive, their liver is very sensitive. So when you start medications, then the liver enzymes may go up a bit. So you have to be very careful. Probably you just cut down the dose. And obviously patient has no other options, have to lose weight, So yeah, sometimes very tricky. All right. So and radiograph and ECGs when it is indicated. So when do we refer? It's if there is a diagnostic dilemma, especially in patients who are not sure whether it's gout or is there any other inflammatory arthritis, okay, or due to therapeutic indications, especially in special group patients. All right, so I've mentioned this in women. Okay, so women rarely they get gout, especially before menopause, because estrogen is a uricosuric. Okay. So in young men, but I think nowadays we see a lot more of young population because of the diet factors. But if young patients, you should also think of other differential diagnoses, especially those without risk factors. So risk factors I've been mentioned before. Therapeutic indication, those who fail to treatment, fail to the first line, very refractory, recurrent flares, tophaceous gout, okay, so and also patients with hypersensitivity to allopurinol. So these are the patients that need to be referred, patients with pregnancy. All right, so I think in the CPG you may find this the safety of treatment of gout. Sometimes they do when they're pregnant, but very rare women with gout get pregnant. So please refer to the specialty care. Orthopedic, when do we refer? Of course, if there is infection. So whenever you are in doubt, you can treat empirically with antibiotic first, because patients die of sepsis. They don't die because of acute gout. But of course, it's painful, lah. All right. And ulceration, presence of entrapment, joint destruction, instability, impaired motion, and functional impairment. Some of the patient request for earlobe tophi, but again, usually these tophi may recur if you do not control the serum uric acid. So I would say there's no role of cosmetic surgery if you do not control, unless if you have controlled the uric acid level and the tophi remains there. Urolithiasis, of course, by urologist. All right, so these are the recommendation 12. I think you can read this in the CPG. It summarized the indications for referral of patients with gout. So take-home message is ULT should be started if it's indicated in all gout patients, including those with CKD. And allopurinol remain the first line. So please remember, if you want to start Fibrosol as the first line, you have to also counsel the patient, because I think, again, because we are living in medical legal era, so FDA has not removed the black box, so we still have to closely monitor. So that's what happened with the new drugs. So the long term is still not well established. T2T strategy, please remember, treat to target, including patients with CKD. Please initiate prophylaxis for gout flare. So we use colchicine, provided the patient has good renal function. Okay. And again, treatment of gout flares depends on comorbidities. And please refer if you are in doubt. I think that's all. Yeah, thank you. So we go to the Q&A. All right, so what are the options to treat gout flare during pregnancy? So again, there are very limited data. You can go back to the table, but yeah. So NSAIDs is still, it shouldn't be used after 20 weeks because of the risk of the patent ductus arteriosus. And colchicine, yeah, but it is very limited data on this. So I think the best is to refer to specialists for this a special population. If patient has recurrent acute flare within a short time, can we give colchicine again? So again, please do not exceed the recommended dose, which is 3 tablets per day. All right. So if the patient require more than that, you can use steroids, short-term steroids. Okay. Hi, doctor. Can I use dexamethasone? Okay. So dexamethasone is also a steroid, but it has a lot more side effects, and it is very potent. Oh, you have answered. Okay, so it is very potent. Usually we avoid giving dexa. I know that many like to give dexa because it's very potent, but it has a lot of side effects. So usually we give prednisolone. Uh, Dexa has a marked adrenal suppression. So be very careful. Do not give long term. What else? We either can start allopurinol during first flare or after. Okay, so this one actually we selalunya traditionally we wait lah until, you mean first flare, masa flare. So during flare, usually kita tunggulah, because when you initiate uric lowering therapy, it can cause flare. So you don't want pain, right? But in some patients who always had frequent flare, sampai there's no interval of free flare, so you may want to initiate allopurinol, but please give a good dose of pain relief lah to control the pain. When to start allopurinol after given colchicine with NSAID? So again, I think I've answered this. So yeah. Is it necessary to? Oh, no, no, no. Don't. Can we refer to Hansagen even though the uric acid hasn't been achieved? Okay, so it depends on the indication. If let's say it caused a pending tendon rupture, yes. Yelah kan, terpaksa lah. Or if severe carpal tunnel, yes. But it's for a very short term. So the long term to prevent recurrent is by reducing the uric acid. So yes. If you are in doubt, just refer first, because I think there are sometimes the tophi may encroach the tendon and causing pending rupture, so that warrants a repair. What is the prophylaxis? Okay, so CKD ni selalunya, usually CKD patients, I would advise all of you to refer to specialist care, because colchicine, it is not recommended with patients with severe CKD. You can go back to the table, page 6. So if GFR less than 30, you should avoid. So in this kind of patients, again, you cannot use NSAIDs. So what we do is sometimes we give a very low dose steroids, but this is based on personal. There's no evidence. So you can, for me, I can give like 3 times per week, until the uric acid is 5 milligrams prednisolone 3 times per week until the uric acid is achieved to target, and patients I mean, has no flare. But again, do not, but just refer. Otherwise, it will cause cushidoid and a lot of problems. Okay, go on.